Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I have the pleasure of speaking today with Dr. Michael Fine. Dr. Fine describes himself as a community organizer. He is a family physician who had a stint in the National Health Service Corps and then practiced in Rhode Island from 1986 to 2010. He's also the creator of something called Health Access Rhode Island, which is one of the very earliest, if not one of the first, direct primary care services that was developed for his patients. He's also former director of the Rhode Island Department of Health. And today we're going to talk about his new book, Healthcare Revolt. Dr. Fine, thank you so much for joining.
Thank you, Larry, for having me. It's great to talk to you.
So what inspired you to write the book?
I was inspired to write the book because I felt like I needed to tell the truth. I had spent most of my professional life seeing and hearing and pretending that it was all okay. And then I realized that I had the opportunity to understand what wasn't working and why, and what we could do and what we would have to do together. So I thought I ought to put those things down so other people could see and critique those ideas.
Great. Could you give folks sort of an overview? What message are you trying to get across through your book?
I think the messages are pretty simple. What we have in the United States is a wealth extraction system, not a healthcare system. We have a market. We have no way to improve and build the health of all Americans. And what we have never come to grips with is the notion that what we need, if we're going to improve the health of all Americans, what we need is a system that the market has failed us. So that's one sort of big area of concern. And the other thing is, I try to reflect on the notion that this healthcare market is a $3.2 trillion enterprise, of which about $1 trillion or more is unnecessary or wasted, but really comes off as profit. And the people who are taking off that $1 trillion aren't going to give it up easily. If we're going to build a system out of this mess, we are going to have to build a movement. The movement for healthcare in the United States. It's going to take 5, 10, 15 years, and we're going to have to all work together to get it done. But we have done that kind of thing in the past in the United States. You know, we had the abolitionist movement, free slavery. We got suffrage for women. We had the civil rights movement. We had the anti-war movement. We had the movement for marriage equality. We have been able to fundamentally change our society, and we can and ought to do that for health care, and we can and ought to do that and start now.
So could you comment, you were Commissioner of Health in the state of Rhode Island, and you created something called the Primary Care Trust as a vehicle for funding change, creating a tipping point in the system. Could you speak to that?
Sure. The Primary Care Trust we proposed was a way to provide primary care to all Rhode Islanders, which we thought was something necessary if we were going to improve the public's health and control or reduce cost. It turns out that the funding of primary care is a totally predictable expense. It's relatively simple. All the Primary Care Trust does is it lifts a certain amount of money per person per year, puts it into one place, and out of that one place buys primary care in a capitated or per person per month way. We get rid of the billing process. We get rid of fee-for-service. We understand that when you have a system, when you have one place, a place to stand to organize and provide primary care, you can go around and make sure every community has a robust primary care practice that's open from 8 o'clock in the morning till 8 at night, open on weekends, that integrates mental and behavioral health and dental health and physical therapy and lab and x-ray, and do it community by community in every single community of 10 to 20,000 people. And we are very clear that if we could have done that, we would have substantially reduced the cost of health care and substantially improved our health outcomes.
So you had, what you're describing there, as I understand it, is your idea for a neighborhood health station. Could you speak to that?
Sure. And actually, one of the things I'm doing now is getting ready to open the first purpose-built neighborhood health station in the United States. So it's exactly as I just described. A neighborhood health station is a single clinical enterprise responsible for the health of every single person in a geographic community. A neighborhood health station doesn't wait for people to walk through its doors. It opens all the doors it can and aims to make sure that 90% of people in a community can get the services they need in their own community and get 90% of the services they need provided in their own neighborhood.
And what happens to the other 10%?
We assume that the other 10% will try to find or will find primary care in another way. You know, there's plenty of room for this kind of process and direct primary care or private practice. You know, there's no reason that people shouldn't have some choice in terms of how they want to get their primary care and where they want to get it. But the thing that's fundamentally different about this approach, about the neighborhood health station approach, is that we take the approach that everyone in a community ought to have a needs primary care. And if you don't approach it in a systematic way, many people won't understand what we mean by primary care, won't understand what we mean by prevention, and won't really have access to primary care and prevention. But if you approach it in a population-based way, if somebody takes responsibility for making sure that, you know, everybody has had opt-out testing for HIV, and everybody has had a flu shot, and everybody has sat down and had a discussion about health and wellness, how to maintain and build their health, about diet and exercise. When you take the approach that we need to bring that to every single person in a community, then you really have a mechanism to improve the health of the population as a whole in a way we just can't imagine in the United States today.
So
actually,
go ahead.
Just if I may tell a quick story. As I have been touring the state talking about this, I had a woman say, you know, I went and lived in Italy for a couple of years, and I couldn't believe that when I, you know, sort of settled in a place, I registered that I was in that city, and the moment I registered, I started getting postcards and calls about whether I'd had my colonoscopy yet. How did they know I was even there? How did they know about my health care? What was really interesting was, you know, she had moved to a place that took a population approach to health care, that had a health care system. And what we haven't done yet is imagine that we can and should do that in the United States.
So maybe you could comment on this point. So in this country, we have this culture of rugged individualism where everyone's responsible for themselves. How do you address that in the context of population health?
Well, we have rugged individualism, but we also have a common definition of essential services. So we have come to understand that everybody needs primary school and high school education, and we do that together. We've come to understand that everybody needs police protection, and we provide that together. We've come to understand that everybody needs fire protection, that everybody ought to have access to clean and safe water, to sewage systems, and we do those things together. And what we are just beginning to understand, I think, finally, is that primary care is an essential service, and we ought to provide that together, just like we do for these other essential services that are the building blocks of our democratic society.
So, Michael, you're going to be coming to the 2018 FMEC annual meeting in Westchester, the Westchester Hilton, on November 9th. You'll be a plenary speaker for the students, residents, and faculty who are present. What's your hoped for outcome of engaging with that group?
I'm hoping to get everyone there ready to revolt. By that I mean I'm hoping that I get everyone there thinking about what it would be like to build a healthcare system in their own community. Not just study medicine, but to actually engage with businesses and with other people in the community, and think about putting a healthcare system to take care of everyone together. Think about how they might go about doing that in their own community. I'll have examples from around the country about people who have done that successfully. And the outcome I would like is that we see in 5 or 10 or 20 or 30 or 50 or 100 communities, people get going on building a healthcare system to take care of all their friends and neighbors.
Cool. Well, I'd like to support you in that, and I'm hoping that that's exactly what happens. From my point of view, on behalf of the FMEC, one of the reasons we invited you to come and be a speaker is to share that message, get people stirred up, and we're hoping long-term we're planning long-term to build a community of interest around that idea, not just within family medicine, but much more broadly, so that we can create a true tipping point in the United States so we get to a primary care-driven system, not just primary care practices, but a system that's driven by the core values and principles of good primary care. So, Michael, I'm really glad that we had a chance to talk this afternoon. Any final messages for the audience?
Only two. The first final message is, if we can do that, if we can stand up together and start building healthcare systems in our own communities, we'll do more than recreate healthcare. We'll go a long way to resuscitating democracy. Democracy is not something you watch on television. Democracy isn't a spectator sport. Democracy is active connection and participation. So that's the first message. And the other message is, I'm continuously amazed and impressed at how you, Larry, and how the FMEC has really been the spark plug for thinking about innovation and creativity and democracy in primary care, in family medicine, and in public health over the last 20 years. And I can't say enough about what you've done and how you've done it, and I don't think there's anyone who can thank you enough.
Well, it's very kind. Thank you. So how about telling the listeners how they can obtain a copy of your book?
The book is available online through Amazon, or better through PM Press, which is www.pmpress.org. Or actually, I even have my own little website, which is www.michaelfinemd.com. All of those are options, and before long, I hope to have it in bookstores, community bookstores as well.
Awesome. Dr. Fine, thank you very much for sharing your time with us today.
Larry, thank you for inviting me and for everything you do.